So very good evening to all. I think இது வரைக்கும் நம்ம பார்த்த breast diseases வரைக்கும் you would have covered. If you have any doubt in the previous sessions, kindly DM me or you can put in the today's chat box so that we can discuss. So before coming into the session, I think next exam is deferred. So there is a lots of confusion. So only one point I want to add. இப்போ நம்ம பார்க்குற இந்த லாஸ்ட் 2 டாபிக்ஸ் நம்ம பார்த்துருக்கோம், breast 1 and second part. ரெண்டுலையுமே நம்ம பார்த்தது வந்து பார்த்தீங்கன்னா it is going to be helping you in both your next exam or your university exam. Everything is read from the book only. Every important points either they are asked as a short note or essay, or they might ask as a MCQ. In whatever way they ask, it's very easy for you all to write than a post-intern or than an interns, because you have a lot of knowledge. You can read now and you can retain it to write in your exam. So no worries. Without further delay, I think today we will try to complete it before 10:30 along with MCQ discussion. So I have planned such a way that you complete all your disease, and once we can revise the entire thing, whatever we read till now. Okay, so let me start with the session for the day. So to begin with, first we are going to see the breast abscesses. So what is a breast abscess? It is nothing but we also call it as a lactational breast disease. We also call it as a lactational breast disease. The main agent which is going to be causing this breast abscess is your Staphylococcus aureus. We can tell it as a most common, can call it as a most common organism that causes breast abscess. Now moving on towards the source. How does this breast abscess comes? So if you're going to ask me, breast abscess usually comes in a lactational mother. It usually comes in a lactational mother. Why it comes in a lactational mother? Someone can guess me? Very easy. Because of the oropharyngeal infection of the child. Because of the oropharyngeal infection of the child, the mother is going to get infection in the breast. So that is nothing but your breast abscess. Okay, so now coming, what are the clinical features you can find? There will be pain, there will be fever, there will be swelling. Okay, you will find fever, you will find pain, you will find swelling, and the last and final feature or the layer which you are going to find is fluctuation. Okay, you will be having a fluctuation sign. Now moving towards the ultrasound. So ultra is the investigation of choice. Okay, it is going to be the investigation of choice in these patients. Coming towards the treatment, very easy. What is going to be the treatment? Antibiotics. What is the antibiotic that is going to be given for these patients? Amoxiclav. Okay, so once what happened in one of the exam, in INISET or NEET PG, I don't know, in one exam what they asked this, they left this amoxicillinic acid. They just gave cloxacillin, okay, as an option. So cloxacillin is nothing but amoxicillin plus clavulanic acid combination. That is what cloxacillin. Cloxacillin is given in the case of breast is going first drainage. If there is going formation, what you have to do? At least to do a 2 atoms of USG. So do atoms of USG guided, atoms of USG aspiration, USG guided aspiration you are going, because we wanted to check what is the injection that is predominant in this condition. So that's why we are going to do a USG guided aspiration. Or if aspiration fails, if your aspiration is going to fail, then what you will do? Then you will go for incision and drainage. Now, someone, if you have completed your surgery portion, surgery topic, general surgery, can you tell me what is the blade that is used in the USG in the incision drainage? This was once asked as a question in your exam. So in which in incision and drainage, what is the blade you are going to use? Remember, blade used in the blade used in incision and drainage is 11 blade. How to identify 11 blade? This may be kept as your spot in your exam. Remember, this is the only blade. Okay, so your 11 blade is the only blade which is going to be sharp at the end. It will be pointed at the end. Okay, it's going to be like this. This is your 11 blade. Okay, so this is how your 11 blade looks like. This is one used for the incision and drainage. Your 11 blade is the one that is used for incision and drainage. Okay, so now what are the differential diagnosis of your breast abscess? Either this breast abscess can be, this is a Bailey and Love update. So what are the differential diagnosis? Two differential diagnosis. Either it can be a tuberculosis. So TB, my presentation will be there. Number two, it can be inflammatory breast disease. I guess we have discussed this in the first part. So inflammatory breast disease, these are the two non-healing breast abscess that are found. So differential for non-healing breast abscess, if they ask you as a 2-mark question in your exam, the answer is going to be TB, inflammatory breast cancer. If they ask third condition, so Bailey and Love added the third condition now. What is it? Idiopathic granulomatous mastitis. Granulomatous mastitis. Once you always look at this picture, because they can ask you picture-based question if they are having a next, or if you're going to attempt your NEET PG in future, they'll be asking you the age-based question. So this is an image of breast abscess. Okay, now let's move on towards the next one, that is galactocele. Galactocele is going to be an important short note that is asked in your university exam. So what is a galactocele? It is nothing but milk-filled cavity. It is nothing in a lactating mother. So it is called as your galactocele. What happens is either it is going to be a subareolar. Usually there is going to be a subareolar, and this will be unilateral in nature. Okay, so what are the causes of galactocele? So remember, the causes of galactocele are number one, lactational protein. So lactation and the protein. When you give a drug and when you're going to increase the prolactin, increasing the level of prolactin by drug, that can also lead to galactocele. And number three, when there is going to be any obstruction, either in your ducts or whether either in your areolar ducts, or whether it's going to be in your nipple, when there is going to be a obstruction, then you are going to, this is going to lead to galactocele. Now coming towards the clinical feature, very easy guys. The clinical features are, number one, the thing is going to be palpable. Can you see here? So this is what it is. So you're going to have a palpable areola. Okay, then second thing, it is going to be round. It is going to be well defined in nature. It's going to be well defined in nature. And number four, they are going to be freely mobile. Number four. And number five, there is no fever. This you just underline, you just write it bold letters, that there won't be any fever, there won't be any pain. They will have just a swelling. Okay, so what is going to be the investigation of choice? Remember, investigation of choice is USG guided FNAC. USG guided FNAC is going to be your investigation of choice. And what is going to be your treatment? Treatment is again USG guided aspiration. USG guided aspiration. Now tell me, how is your fluid that are going to appear after aspiration? The fluid is going to be a thick, milky, white secretion. How the fluid is going to be there? Fluid is going to be thick, white secretion. Now I have already told you about this very important thing, right? That is going to be your differential diagnosis of non-healing breast abscess. Okay, so what are the three non-healing breast abscess I told you? The three non-healing breast abscess, I told you. Okay, it is going to be your number one. Someone, can you tell me in the chat box, what are the three non-healing breast abscess I told you just now? Can someone tell me in the chat box? Number one, it is going to be idiopathic granulomatous mastitis. Number two, it is going to be a tuberculosis. And number three, inflammatory breast cancer. So we have these three conditions. Your Bailey and Love, recent edition of Bailey, 28th edition, tells you how to differentiate these three conditions. So first, what you're going to do, you're going to go for a biopsy. Okay, biopsy panningana, you will be seeing a granuloma. So after you see granuloma, now you have two conditions. Either it can be inflammatory granulomatous mastitis, or it can be TB, tubercular meningitis. So So what you're going to do, you're going to go for a gene expert. So you're going to go for gene expert. So gene expert, it will be negative if it is going to be not a TB. Then you're going to go for AFB. AFB also turns to be negative. So then, okay, these two are not there. Only if these two are negative, you can go for the treatment of steroids. Okay, so in the inflammatory granulomatous mastitis, the treatment of choice is going to be steroid. Remember, in inflammatory granulomatous mastitis, the treatment of choice is going to be your steroid. So therefore, only after eliminating the tuberculosis, you're going to go for the steroid treatment. If you are going to give steroid in a tuberculosis condition, then it will worsen your situation. So remember, it is going to worsen your situation. That is why you won't give steroid without testing a biopsy, without doing AFB. Is it clear? Next, we are going to move to a very important condition that is going to be. So in your book, SRB manual or in your Manipal, they'll be giving a lot of things about, and I will tell you in short what is the thing, but abrasion. Okay, abrasion of non 15 to காமனா வருது அடினோமா. இதுதான் உங்களுக்கு தெரியணும். ஓகே, 15 to 25 years of ageல காமனா வரது எது அப்படின்னு பாத்தீங்கன்னா, it is going to be your fibroadenoma. It is going to be fibroadenoma. Number 2, when you are going to see about 25 what commonly occurring is fibroadenosis. And number 3, okay, which is going to be your number 3, more than 40 years, you have fibroadenosis again. So this is also again a recent guidelines. Adenosis is going to be most common than your ductectasia. From this itself, you would have understood now that what all we are going to see. We are going to see all the benign breast diseases. For benign breast diseases, they are given you certain diseases like your fibroadenoma, fibroadenosis, ductectasia, etc. So that is what we are going to see in this upcoming topic. Number 1, very, very important question, repeatedly asked university exam. Remember, repeatedly asked university exam. Okay, FAQ, frequently asked question. So anything you can tell it. So this is going to be a frequently asked question in your exam. So this will be kept as a spotter for you. This will be kept as a given case for you in university. Therefore, always remember the important features of fibroadenoma. So fibroadenoma, it arises from hyperplasia of single lobule. Very, very important keyword. Okay, this is going to be arising from single lobule, hyperplasia of single lobule. Okay, the properties are going to be well circumscribed lesion. Number 1, it is going to be very smooth, it is going to be firm, it is going to be nodular, it is going to be mobile. Now tell me, which is called as a mouse breast? Your fibroadenoma is called as mouse breast. Why you call it as mouse breast? Because it is going to be very, very mobile in nature. That is why you call it as mouse breast. So this is going to be non-tender in nature. This is going to be a biphasic tumor. Why I call it as biphasic tumor? Because at the younger age group also this occurs. At a elder age group also this occurs. This is going to be having a bimodal pattern. Okay, so that is why we call it as biphasic tumor. And remember guys, according to Robbins, that's a latest Robbins. Okay, you would have not read the latest Robbins, I hope so. According to the latest Robbins, 2/3 of fibroadenoma, this is going to be arising from gene called as MED12. Your MED12 is what that is going to cause the fibroadenoma. This is according to the recent guidelines. Yeah, okay. Then remember, what is going to be the BI-RADS score of this? BI-RADS score is going to be 2. That's 2. This is according to BI-RADS 2. So the patient will have a positive for family history. Okay, there can be a rapid increase in side. Okay, in one side there can be a rapid increase in side. Okay, there can be a pain. Okay, pain can occur. Okay, once if all these features are going to come, then you're going to go for a surgery. what is going to be the surgery? Remember, what are the indications of surgery? Number one, when there is a family history. When there is a family history, this can be asked as a 2-mark question. Kindly note down. When do you do surgery for fibroadenoma? Number one, when there is a when there is a rapid increase in size. When there is a rapid increase in size. Third one, when the patient to experience pain, starts to experience pain. Number 3 and number 4 is going to be cosmetic. Okay, cosmetic indications. Then you're going to go for surgery. Or when there is going to be a fibroadenoma more than 5 centimeter, can someone tell me in the chat box what is going to be the fibroadenoma more than 5 centimeter called as? Remember, fibroadenoma more than 5 centimeter is called as giant fibroadenoma. Giant fibroadenoma. Very, 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 very important point. Then I want to talk about VABS. What is VABS? Vacuum assisted breast surgery. Okay, this is going to be very, very important topic because this has come recent updates. Okay, they might ask you in exam also as a short note. Okay, nowadays if you see, there are lots of recent days asked as a short note, plus a procedure can be asked as a short note. Therefore, this VABS can be asked as a short note. What is VABS, guys? VABS are nothing but vacuum assisted breast surgery. It is a vacuum assisted breast surgery. Okay, wow. So this is going to be a scarless surgery. There's going to be a scarless surgery. What is the needle probe you are going to use? We are going to use a 7-gauge probe. Okay, we are going to use 7-gauge probe, and this is easy to remove. You can remove multiple fibroadenoma. Okay, wow. Can you see this picture? Can you observe something? In mastectomy, the entire cosmetic features will be lost for a breast. But in this picture, can you see a small hole can be put and the probe can be inserted and the fibroadenoma can be cleared off. So that is why this VABS is going to be now a popular treatment of choice. Okay, so clear, that is called as VABS, vacuum assisted breast surgery. Okay, next we are moving towards this phylloid tumor. Remember, phylloid tumor is otherwise called as cystosarcoma phylloids. Cystosarcoma phylloids. So it is called as cystosarcoma phylloids, or you can also call it as we can also call it as what? Can also call it as serocystic disease of Brody. Can also call it as serocystic disease of Brody. Remember, guys, there are 2 types of Brodies actually. You will read about this Brodies. Even in orthopedics, the same name will be coming, Brody's abscess. So Brody's abscess, you're going to see in the pyogenic osteomyelitis, a type of pyogenic osteomyelitis, you will read as a Brody's abscess. Similarly, in the breast also, you're going to have a Brody's abscess. What is Brody's abscess? This is going to be a very important rapidly progressive breast lump. So rapidly progressive breast lump. Okay, you can see a lobulated pattern. And there is going to be a dilated veins present over chest wall. Okay, dilated veins present over chest wall. Okay, so this is usually occurs at more than 40 years, usually in 3rd or 4th decade. It's usually going to be present in 3rd or 4th decade. Clear? So this originates due to the hormone responsive stromal cells. So this is going to be due to hormone responsive stromal cells. So hormone responsive stromal cells nalada in the phylloid tumor varudhu. Okay, very, very clear. Okay, less than 10%, it can go for a metastasis to the lymph node. Lymph metastasis can occur. Okay, metastasis eppadi pogum அப்படினு கேட்டிங்கனா metastasis oda usual route is going to be your bloodstream. Okay, usually it can go to bloodstream. Remember, guys, less than 10%, again, most commonly they can go for malignancy. Okay, so they can go for malignancy. If it goes for malignancy, where it is going to be getting metastasis, so lungs ku pogum. Remember, so distant metastasis la most common enga அப்படினு பார்த்தோம்னா lungs. Okay, metastasis la most common enga நடக்கும் அப்படினு பார்த்தோம்னா to the lung. Then what you are going to do? We are going to go for a treat. The investigation is going to be your true cut biopsy. So you are going to go for true cut biopsy. True cut biopsy is going to be your investigation of choice. So a short note or essay or என்ன point எதனும் இதிலேயே நான் சொல்றேன் உங்களுக்கு. Can just clearly note it down. So true cut biopsy, where you're going to do? You're going to go do it immediately in the phylloid tumor. If you're in your true cut biopsy, you're going to see increased stromal cellularity. Increased stromal cellularity. Number one, if you're going to see a overgrowth, if you're going to see a typical leaf-like appearance, if you're going to see a typical leaf-like architecture, okay, leaf-like architecture, if you're going to see something like this, then this is going to be your malignant, okay, this is going to be your phylloid tumor. See here, so a leaf-like output you can see, right? This is going to be your phylloid tumor. Now, coming towards the investigation, can you see here? So your phylloid tumor looks like this. Your phylloid tumor looks like this. You have to understand that in your phylloid tumor, you're going to see a X-ray, like if you're going to see a mammogram like this, then you wanted to confirm whether it is malignant or not. So depending upon the situation of malignancy, you will be going for the surgery or not, you can decide. So how is this phylloid tumor? I'll give you the features. This is going to be very bigger in size. It's going to be much bigger. You're going to have a smooth margin. You're going to have a smooth margin. You're going to no infiltrations are present. No infiltrations are present. So what is the differential diagnosis? You will be differentiating it from the fat necrosis. How are you going to differentiate it from fat necrosis? Fat necrosis, like you will have a eggshell calcification. You will have a eggshell calcification. There are palpable mass, whereas here that is not going to be very much palpable. Okay, so the mass cannot be palpated, differentiating it. Is it clear? Now moving on towards the treatment. So treatment aspect is going to be, now you have to know whether you want to do a surgery or not. In surgery, whether you're going to do just lumpectomy or you're going to do a simple mastectomy. Simple mastectomy. Where will you do a simple mastectomy? You will do a simple mastectomy if, what are the indications? Okay, so you will be doing when there is a recurrent phylloid. When there is a recurrent phylloid. Or number two, when it is going to be malignant. Okay, number three, when it is going to be very large. You know, right? I told you already one concept. Breast and your chest ratio you're going to take. If it is going to be more, then you will prefer a simple mastectomy. Now moving on towards the treatment. So your treatment is going to be, in this case, you will be doing a excision with margins. You're going to cut the margin at least 1 centimeter, at least 1 centimeter. Okay, now moving towards the clinical features. Remember, this will be this will be unevenly bosselated and they remain mobile. Okay, so don't need to fear for that. And if at all it's going to be a malignant, remember, so these two conditions you can leave just with this excision with margin excision. If you are going to have a malignancy, then what you will do? You will go for a radiotherapy. Okay, you will be going for radiotherapy. But remember, there is no need for lymph node clearance. There is no need for lymph node clearance. Okay, so as I told you, fat necrosis, just remember, just you have to know what is this given picture is. Okay, how do you differentiate it from the phylloid tumor? Remember, fat necrosis is going to be a palpable tumor. It's going to be a palpable tumor mass. Okay, number two, this will be looking like a eggshell calcification. This is called as eggshell calcification. I think I have explained you this while I am taking a mammogram in the first part. So this is called as eggshell calcification, and you will be seeing this in the young woman. Okay, remember, they don't have a malignancy potential. No malignancy potential. This you need to remember. No malignancy potential. Is it clear? Okay, now moving on towards the mastalgia. Okay, mastalgia na enna? Pain. Okay, mastalgia means breast tenderness. There is a breast pain. Okay, mastalgia is nothing but it is going to denote the breast pain. Remember, you can divide this mastalgia into two conditions: cyclic and you can divide into non-cyclic. What are the conditions that are going to be coming under cyclic? You will have a big list of cyclic and non-cyclic mastalgia in SRB manual or in your Manipal. But for now, for easy understanding, remember, so you will be having a cyclic in your fibrocystic, okay, or okay, fibrocystic or fibroadenosis, you will be having a cyclic. So this will be under the age group of 25 to 40 years. This will be under age group of 25 to 40 years. What are the non-cyclic mastalgia causes? Number one, you have a Tietze syndrome. Tietze syndrome, number one. Okay, or also called as costochondritis. Number two, this can be asked as a short note for you, Monders disease. So this is your Monders disease. This can be asked as a question for you. Okay, so now moving on towards cyclical. What are the causes of cyclical? Okay, so cyclical breast pain causes we have seen fibrocystic adenosis. This occurs in the age group of 25 to 40 years. Now, after knowing this, what are the clinical features? Remember, pain will be before the periods. So before arising a menstrual period, the patient will be having a pain, and then this is going to be settling. This is going to be settling and increases again in the next cycle. So before every cycle, okay, patient will have pain. Okay. Next cycle. Number 3 is going to be where nodularity in the breast. Patient will be having a nodularity in breast. Is it clear? Okay. So what is going to be your investigation of choice? USG is going to be the investigation of choice in this condition. So this is going, your USG is going to be the investigation of choice in the condition. Now moving on towards the non-cyclical. Okay, non-cyclical, you're going to have cyclical. I told you non-cyclical. I told you number one, Tietze syndrome. In Tietze syndrome, there is going to be pain present at the costochondral junction. What is going to be your Monders disease? Remember, Monders disease is going to be your superficial thrombophlebitis. Okay, superficial thrombophlebitis. So there is going to be a chest vein engorgement. So there is going to be chest vein engorgement. Engorgement is going to be present. So this is going to be having an increased risk in smokers. Okay, increased risk in smokers. And what is going to be the treatment of choice? Treatment of choice is to rule out cancers. You are going to rule out the cancer. You are going to control the pain. Pain should be controlled. And then thrombophlebitis, we will be giving tropical heparinoid. Okay, that is called as thrombophobe. In all your medical colleges, you will be having this thrombophobe in your surgery ward. Thrombophobe is going to be a treatment of choice for the when there is going to be a engorgement of vein and when there is going to be thrombophlebitis. So topical heparinoid is that combination which is given. Now coming towards the, okay, this I have taken from Rowan sir notes. So the treatment of choice is going to be your, okay, always remember, avoid caffeine. In these patients, what are going to be your assurance given? So remember, first one, you have to exclude the cancer. Once you're going to exclude the cancer, you're going to reassure the patient. After reassuring, you're going to give adequate support. Adequate support பண்ணிட்டு என்ன பண்றீங்க? Tight sports brassiers wear பண்ண சொல்றீங்க during the daytime and use of VAS breast pain chart to record the severity. Then you're going to consider medication. What are the medications you're going to consider? Number one, flax seeds, 30 mg daily, or you can give oil of evening Primose. So this was asked as a MCQ once in the entrance exam. Second thing is topical non-steroidal anti-inflammatory cream like diclofenac or piroxicam. 4 times a day you can give. Okay, so these things, from your reassurance to your topical non-steroidal anti-inflammatory cream, this can be given for 2 months. This can be given for 2 months. Then If at all the pain is not decreasing, then what you're going to do, you're going to go for a systemic medication. So when the pain score is more than 3, then you're going to go for systemic medications. What are the systemic medications you're going to give for these patients? Number 1, tamoxifen 10 mg daily for 3 to 6 months. Tamoxifen 10 mg daily for 3 to 6 months. Number 1. Number 2, anazole, you're going to give for again 3 to 6 months. And ormeloxifene, you can give for 30 mg twice for 3 weeks. Or you can go for centochrome. Why you're going to giving centochrome? Centochrome can be given for the patient who are going to have nodularity. Okay, so then you can go for LHRH agonist or with combination with tamoxifen or ormeloxifene. So all these are the drugs which are given in the treatment of breast pain. I think you are completed with the treatment of breast pain. Moving on towards a very important thing, when there is going to be a nodular or lumpy breast, when the patient is going to have a nodular or lumpy breast, we will go for one important assessment along with your triple assessment, that is going to be a Cardiff Lucknow nodularity scale. Cardiff Lucknow nodularity scale. Remember this. This is once again an update from your Bailey and Love 28th edition. So what is going to be the update given in this? The thing is, Cardiff Lucknow nodularity scale, which was devised by the AIIMS Delhi, previously. Now it is added in the standard textbook. That means this can be asked. What does this tell? So remember, so the main causes of a discrete breast lump are again divided into 0 to 5 scale. You're going to divide it into 0 to 5 scale. So according to this, the treatment of choice is going to be differing. That is why you need to know the Cardiff Lucknow breast nodularity scale. Just remember the name. That's all. Now moving on towards the next one, that is going to be your breast cyst. Remember, the breast cyst can be divided into simple cyst. Okay, if there is going to be a simple cyst, you can just observe in the patient, or there can be a complex cyst. If going to be complex cyst, is going to be BIRAT 4 criteria. Okay, I think if you are not known what is BIRAT, kindly go to your previous video and check out what is BIRAT. Okay, now moving on towards, so in breast cyst, what happens is there will be a smooth wall disease, without compartment. So without solid component, no solid component, then for a BIRATS 2. Okay, it's going to be a BIRATS 2. If it is going to be a BIRATS 2, remember guys, you're going to just observe, only observe. Okay, if it is going to be presence of solid component, if there is going to be solid component, then it is going to be a complex cyst. If you term it as complex cyst, you need to do core biopsy. Okay, why you're doing core biopsy? To rule out CA. Okay, once you do core biopsy, the third point is going to be, if you're going to do a core biopsy, in that you can, if you're going to find intracystic floating debris, okay, if you're going to find intracystic floating debris, okay, then you're going to call it, you're going to call it as complicated. Okay, you're going to call it as complicated cyst. And in this patient, you're going to go for an antibiotic. Okay, this is the procedure. I'll tell you once again. So if you're going to have a breast cyst, what you're going to do, you're going to go for an aspiration. Okay, if you're having a solid compartment, then you're going to go for aspiration. In aspiration, it's going to be clear. Then you need no treatment. If there is going to be a blood filled, if you're going to have a blood filled, then you're going to do a core. Okay, then you're going to do a core biopsy. In core biopsy, if you're going to see, then you perform a excision. Is clear? So clear, guys? So this is what we are going to do in the breast cyst. Now moving on towards the nipple discharge. I think one of the favorite questions for your Viva examiners to ask you from this is the nipple discharge. Yes. Number 1, what is the causes of milkish discharge? Lactation. Why in lactation? There is going to be increased prolactin. Why there is an increased prolactin? due to some medicines, cabergoline, bromocriptine, they can cause milkish discharge. Next, you see that clean. When there is going to be a clear discharge, what are the causes of clear discharge? Remember, puberty. So during the time of attaining puberty, during pregnancy, when there is a cancer, what I need you to understand. Then you are going to move towards greenish. Then you will find a greenish discharge. You will find ductectasia. Always after finding this greenish discharge, we usually have this idea, we usually have this mind to go towards the famous bacteria which is going to be causing a greenish discharge in all other conditions. That is your pseudomonas. Never think of pseudomonas here. Here the reason is ductectasia. Here the reason is ductectasia. Clear? So there will be multiple ducts in this condition. Next, what are the conditions where you will have a bloody discharge? So this I can divide again into two. Okay, single duct landu vara problem agirunda, that is going to be your bacteria. Okay, that's going to be your duct papilloma. That is going to be your duct papilloma. Okay, when it is going to be bloody, okay, having a multiple duct involvement. In which condition there will be having a multiple duct involvement? In case of cancer. In case of cancer. Is it clear? Okay, that same thing I have given you here. Discharge from surface Paget's skin diseases. Discharge from single duct blood-stained intraductal papilloma, intraductal carcinoma, ductectasia. Serosanda fibrocystic disease, ductectasia and carcinoma. Discharge from more than one duct, blood-stained carcinoma, ectasia, fibrocystic disease. Green color, this is very important. Ductectasia, serous, fibrocystic disease, ductectasia, carcinoma. Remember, this is asked as a short note for you in the exam. So kindly take a screenshot of this one. This is going to be just a summary of what all you have read. So remember, the most common cause of blood-stained discharge from single duct is duct papilloma. Most common cause of blood-stained discharge multiple duct is going to be your duct carcinoma, and the most common cause of serous discharge from the breast is fibrocystic disease of breast. Is it clear? So shall I move to the next one? That is going to be your duct papilloma. What is a duct papilloma? This is going to be the most common cause of bloody nipple discharge. This is going to be the most common cause of discharge. Okay, bloody discharge from your nipple. Okay, wow. So remember, so 10% of cases, 10% cases can go for a multiple papilloma. 10% can go for a multiple papilloma, and 10% can be associated with DCIS. DCIS, 10% can be associated with DCIS. I think I spoke what is DCIS already. So if you don't know, go back and read what is DCIS. Just 10 to 15 minutes we are going to be discussing. That's all. We are going to complete this entire breast chapter today. Okay, is it clear? Just hold on for 15 more minutes. Now, what is going to be your diagnosis? Remember, guys, how you are going to diagnose? By USG guided, USG guided, USG guided, you're going to go for a dilatation. Okay, dilatation, and you're going to see the mass lesion inside. You're going to visualize the mass lesion inside. Okay, how you're going to do? I'll tell you, I'm not going to write, just visualize. A stiff nylon suture is going to be passed inside that duct. Now you're going to fix the probe to the nipple and skin using a skin suture so that it will not get displaced during the procedure. Now what you're going to do, you're going to cut a flap, a triangular flap 1 millimeter away. Then what you're going to do is you're going to take a probe, and with that you're going to excise the skin flap for 5 centimeters till the bandage is applied. So why you're going to do this? To take a picture, can you see here? This is what I told you. Number one, I'll tell you. First, you're going to pass a nylon thread. After passing a nylon thread, what you're going to be? You're going to insert that. Okay, what you're going to do? Then you're going to insert the. You're going to put that. Then what you're going to do? You're going to put a thread vechi pannite. Then we are going to actually put. We are going to put that. You're going to put that stain inside. Then what you're going to do? You're going to cut a triangular flap. Can you see here? So here we are going to actually cut a triangular flap, and this incision. So can you see an incision here? So this incision is called as tennis racket incision. Incision is called as tennis racket incision. Is it clear? This incision is called as tennis racket incision. So what you're going to do is you're going to put a probe, you're going to excise the skin flap. So then what you're going to do is you're going to take that flap, you're going to put a frozen section biopsy. Why do you do a frozen section biopsy? Because I need to understand what is the problem there. Once I understand the problem, I can treat accordingly. So remember, what is going to be your treatment of choice here? Once you prove it as a duct papilloma, what is the treatment of choice? Remember, one and only condition, okay, where you're going to do the microdosectomy. This is going to be the only condition, duct papilloma, where you're going to do, what you're going to do is remove that duct and the lump together. If features of ADH is going to be seen involving more than 2 ducts, then we term it as a duct DCIS. Okay, ductal carcinoma in situ நம்ம name பண்ணிடுவோம். Papillomaங்கிறது it's going to be a central fibrovascular core having a papillary projections of epithelium. So that is what typically you call it as a duct papilloma. So solitary papillomaங்கிறதுக்கு risk rate வந்து பாத்தீங்கன்னா 1.5 to 2 தான். அதே when you're going to go for papillomatosis, more than 5 risk factors இருக்கு. So what is juvenile papillomatosis? I want to add this only one condition, juvenile papillomatosis. If they ask you as 2 more question, remember guys, this is called as Swiss cheese disease. Swiss cheese disease. So the same surgery, same investigation of choice, everything is going to be same, except that this is very common in young females. Okay, young females are most common. This will be presenting with a multiple papilloma. This will be presenting with a multiple papillomas. That's all. Okay, next we are moving towards the next topic. That is going to be your duct. We are going to call it as ductectasia. This is going to be occurring more than 40 years of age. Okay, so what you are going to be there? I told you already. You're going to have a greenish discharge. Okay, you're going to have a greenish discharge from multiple ducts. Okay, from multiple ducts you are going to have. Then alveolar sinus will be there and abscess formation will be there. Alveolar sinus and abscess formation will be there, and there is going to be multiple ducts that are going to be present. How do you do the diagnosis? By USG. Why you are going to do USG? To rule out cancer. You are going to do to rule out the cancer. Okay, if you are going to do a biopsy, remember, if you are going to do a biopsy, periductal mastitis. Okay, mastitis apart. So if you are going to find it as a periductal mastitis, you call it as Zaskar's disease. This is again asked as a previous question, asked as a 2-mark question. Okay, what is Zaskar's disease? Zaskar's disease is a periductal mastitis, which is going to be presenting very similar to that of ductectasia. What is going to be your treatment of choice? Antibiotic. Okay, that is going to cover both aerobes and anaerobes. If it is going to be persistent, if you're going to have a persistent, then you're going to do for cone excision. Then you will do a cone excision of ducts. So this cone excision of ducts is called as Hadfield procedure. Okay, so your duct cone excision of your duct is called as Hadfield procedures. Now coming to the Paget's disease, very, very important, asked as a short note question for you all in your university exam. What is Paget's disease? It is going to be a unilateral disease. There is going to be eczema-like condition that is going to be due to the destruction of nipple areolar complex. There is going to be a complete destruction of the nipple areolar complex. So what happens? 70% have underlying lump. Okay, remember 70% will have underlying lump sometimes in their life. Okay, and investigation of choice is going to be always you go for the, what will be the investigation of choice? Someone, can you tell me what is the investigation of choice in your Paget's disease? You will again go for the USG. What is going to be your management? Lumpectomy. Lumpectomy is going to be management, and surgically you can also give a cosmetic corrections. What is eczema? Again, eczema, it's going to be bilateral in condition. There is no destruction of nipple areolar complex. Therefore, there is no lump present. So, verum treatment is going to be just giving steroids. You're going to just giving steroid. Nothing you're going to do. Just you're going to give us steroids for these patient. Okay. So, Paget's disease of bone, Paget's disease of bone, Paget's disease of breast. You know to differentiate between the two. Remember, your Paget's disease going to diagnosis apart from USG, you will go for a punch biopsy. You will go for a punch biopsy. Okay, punch biopsy povenga. Usually the Paget cell will be like ER-PR negative, and your CA will be positive. Your CA will be positive. This is very, very important diagnosis you need to understand. So how will be your punch biopsy? In punch biopsy, you will be seeing a pale vacuolated cells with round or oval nuclei. This is what you'll be seeing in a punch biopsy. Treatment is going to be either lumpectomy or you can go for mastectomy also. Either you go for lumpectomy or you can go for mastectomy. Now, moving on towards a very important once again. This is always enlargement of male breast. Enlargement of male breast is called as gynecomastia. There are two important causes. It can be a physiological cause or a pathological cause. Physiological cause, example, someone, number one, it is going to be newborn. Number going to be due to puberty. Number two, it's going to be puberty. Number three, senile in nature. Vaisanale, it will be coming. Pathological, number one, you remember, idiopathic. And number two is going to be drug caused. Okay, it is due to drug. So what drugs? Remember it as disco. Remember this as disco. D stands for digoxin. Okay, I stands for isoniazid, and S stands for spironolactone, or you can also remember it as steroid. Number four, you're going to remember it as semifidin. Okay, or C my ketoconazole. Okay, you have this ketoconazole. Okay, and you're going to have O stands for estrogen. Okay, so these are causes. These are going to be the causes of your enlargement of breast. So these are going to be the causes of enlargement of. Okay, remember, now we are moving on towards the what is going to be your treatment. Remember, liver diseases. You will see this gynecomastia in liver diseases. You will also see in Klinefelter. You will see in Klinefelter's disease. Klinefelter's you will be seeing. You can also see it as a paraneoplastic diseases. You can see it as paraneoplastic diseases. So no, they are not going to be any metastasis, and conversion of it to a malignancy is very rare. Okay, this can be also seen in leprosy and mumps. Okay, in all these conditions, you can see enlargement of the breast in male. And how do you diagnose? We diagnose using liposuction. You will do a liposuction and gland excision. At the end of this topic, I will go for the difference between Paget's and eczema, which is asked as a short note for you guys. Now, moving on towards the last one more page I'm having. Okay, last one more page, last 15 minutes. Now, coming towards the breast reduction surgery. Remember, so this was asked in entrance exam perspective in JIPMER papers. Previously, it was very repeatedly asked question, guys. Okay, so breast reduction surgery, in a type of pattern, you will give an incision. Okay, incision we will be giving at the inverted T pattern. Okay, so distance between two nipples, it is going to be 19 to 21 centimeter. Distance between two nipple is going to be 19 to 21 centimeter. So this is what you need to remember. Okay, this is going to be a nipple, right? So what they will do is they will be putting a circular incision like this. Then they will put like this, they will be putting. So this is how the incision is given in the breast surgery. Okay, can you understand this? How they will be giving in the breast reduction surgery. Now moving on towards what is going to be called polymastia. Can you see here? So this is going to be the next policy. Polymastia. I think you are all in line with me. Polymastia. These are the abnormalities that you're going to see the breast tissue. What is polymastia? It is nothing but accessory breast tissue. Accessory breast tissue. Can you see here? So this is going to be in the act. You're having accessory breast tissue. Then what is going to be the most common site? Most common site, as you see in this picture, axilla is the most common site, and it can also occur along the line of skulls, or otherwise called as your milk line. So remember, so this is going to develop along the milk line. Normally milk line appear agum. Milk line it appears at 6th week of embryo. 6th week of embryo. So what is this is going to be? This is going to be a ectodermal in origin. Ectodermal in origin. Ectodermal in origin. And this is going to be very prominent. This can become prominent during pregnancy. Now, if you're going to ask me what is going to be the management, okay, if you ask me what is going to be the management, so if there is going to be a cosmetic issue for the woman, then they can go for the removal. Then they can go for removal of this particular lump. Okay, you can remove the particular lump. You can go for a mastectomy. You can go for mastectomy. Mastectomy means in the part not the rest. This part alone can be removed. Okay, what is going to be called as amastia? Remember, amastia, and someone, can you tell me what is amastia? Amastia means absence of breast tissue. Absence of breast tissue, you call it as polythelia. This can be asked as a MCQs for you guys in exam. Polythelia means accessory nipple. Accessory nipple. Okay, so it's called as accessory nipple. What is amasia? Amasia means absence of breast tissue. There is going to be absence of breast tissue, but remember, nipple areolar complex is present. Nipple areolar complex is present, but remember, in our amastia, everything is absent. But in the amasia, okay, there is absence of breast tissue, but there is going to be a presence of nipple areolar complex. Nipple areolar complex is going to be present. Okay, so then what happens is, next we are going to see this Poland syndrome. What is Poland syndrome? Poland syndrome is, this is going to be associated with absence of sternal portion of, there's going to be absence of sternal portion of, okay, pectoralis major. Pectoralis major. So complete a pectoralis major muscle irukad in the patient. That is called as Poland syndrome. This is also recent update. So this is going to be a recent update from your Bailey and Love. Okay, Bailey and Love recent update. Therefore, I think this you need to read. Okay, Poland syndrome is going to be associated with absence of sternal portion of your pectoralis major muscle. What happens is, breast tissues illa, you won't have breast tissues in this condition. Breast tissues are going to be not there. Along with it, major is also not there. Both these are going to be absent. So what are the causes? Remember, the causes are: number one, any radiation in history. Okay, radiation history. Number two, exposure. Okay, previous excision, exposure to radiation, excision of any mass. Okay, misdiagnosed mass. So if a female doctor is diagnosing, surgeon is diagnosing as a breast mass, but unfortunately that was a breast bud. So there is going to be excision of misdiagnosed breast mass. So that is going to be your breast bud. When you are going to remove that, so that can cause. And number three, incision and drainage of abscess. When there is going to be incision of drainage of abscess, that can lead to Poland syndrome. Okay, so Poland syndrome, what are the clinical features you are going to face? Number one, there is going to be amastia. Number two, abnormal chest muscle, abnormality in chest muscle. Number two, and what is number three? Loss of costal cartilages. Loss of costal cartilages. And number four is going to be digital abnormality. So there is going to be abnormal development of digits. Okay, so fingers abnormal development இருக்கும் Poland syndromeல. ஓகேவா? So Poland syndrome genetically வருது. So அது வந்து non geneticalaவும் it can cause. அதுதான் first நான் சொன்ன radiation, excision of mass, breast bud removal and incision and drainage. Okay, so I think with this we have completed the entire topic of breast. One thing which I have left is Paget's versus eczema. Paget's versus eczema. Paget's is going to be unilateral. Eczema is going to be bilateral in nature. This is going to be common in menopausal age group. Menopausal age group. Whereas this is going to be present in the lactating woman. This is going to be present in the lactating woman. Number 3 is going to be distinct edges. This is going to have a distinct edges, whereas this is going to have a indistinct edges. And number 4, vesicles are absent here. There is no vesicles, whereas here you will be having vesicles are present. And number 5, there will be your nipple which is going to be destroyed, whereas in your eczema your nipple is going to be intact. Number 5 is number 6, there will be lump which is going to be present. No underlying lump which is going to be present. So clear? With this, we are actually completing the entire topic of breast. I think I gave you the word. I'll complete it before 10:30, I think, but I have completed at 10:09 itself. Okay, there are no issue. Now, I think I wanted to discuss few MCQs. Can we go? I think if you can answer me, it will be very easy for me. Okay, so shall we go, or shall we have it as a test and discussion later? According to the decision of 4 or 5 who are present in this thing, if you tell me, I can just proceed accordingly. Do you want me to discuss MCQs now, or can we discuss MCQs later? Okay, so meanwhile, if you have any doubt, you can just ask me in the chat box. This is going to be a very easy topic. Actually, breast is going to be very, very easy. Remember, believe me, you have very small thing which you have called breast, that is going to be nearly, it's going to be comprising at least or 100 pages in your textbook. But when you're going to read it like this, 1 hour, I think 3 hours, I think we have completed the entire topic. Importance are very less. We can extract the important things and we can go. I think there is no response. Then what I will do is, we will conduct a test in the WhatsApp group. After the completion of test, we will go for a discussion. Okay, so let me convert it as a test and discussion in the coming Sunday. Okay, let's have it on Sunday. We will do a test and discussion on breast. Then we will move it to the next topic, trauma and management. Trauma, burns, and all those bulk topic is there. That is from general surgery. I think I will discuss that entirely in detail. Okay, thank you so much, guys. Have a great night. Please share all your feedbacks with me. Also share this video with others so that let them get benefited. There are 3 parts in this. We have 3 parts for breast diseases. First part, I have covered the imaging and all those things. Second part, I have covered the entire breast cancer. And third part, now I am covering the benign disease of breast. Okay, I think I'm clear. If you have any doubt, you can post it in the chat box or in the comments, or you can put it in my phone so that I can just DM me so that I can clarify you all. Okay, thank you so much. Thank you, and we'll meet you again in the next session. Okay, tomorrow we have a class on hypertension by Dr. Rashmi ma'am. So I think I want you all to attend that session also. It will be very interesting. Unlike this, you will be guided by one of the fantastic teacher, and she is a teacher of mine also. So let's hope for a beautiful class tomorrow at 7:30. Thank you so much.